Welcome to a new episode of Medicine in 3 minutes. As usual, we go straight to the point. The subject is briefly made clear and often illustrated. Let's start. Today's topic is about the middle ear. Before dealing with the medial wall, here's the summary of the previous presentation. Middle ear is enclosed between external ear and inner ear. It's an air-filled cavity within the petrous part of the temporal bone. Here's the lateral wall, the medial wall, 3 ossicles, malleus, incus, and stapes. The roof, the floor, anterior wall, posterior wall, and medial wall, malleus, incus, and stapes. Anterior cranial fossa, posterior cranial fossa, middle cranial fossa, and the anterior wall, the posterior wall, the lateral wall, or membranous or tympanic wall, and the medial wall, or labyrinthic wall. Tympanic membrane, 2 parts, parts flaccida in green, and parts tensa in blue. The malleal stria and the ambu, the long limb of incus, the posterior stapes limb, and the tendon of stapedus. Anterior malleus fold, posterior malleus fold, and mallear prominence. Let's start with the medial wall. Inside the middle ear, the anterior wall, the posterior wall, the roof, and the medial wall. There is oval window, a round window, and promontory. Here's the eustachian tube in the anterior wall, and pyramid and auditus in the posterior wall. Here's an overview of the fascial nerve to understand the anatomy of the middle ear. From the brachiomotor nucleus, SVA fiber penetrate the internal auditive meatus before reaching the facial canal to join the geniculate ganglion. From there, the fiber follow the canal horizontally, then they descend vertically in the thickness of the posterior wall, and they give the nerve of stapedus and chorda tympani before reaching the foramen, the stylomastoid foramen. Then they give extracranial branch for the fascial expression. From brachiomotor nucleus, SVA fiber coming from the fascial canal until the geniculate ganglion. From the geniculate ganglion, there is a fascial canal, and SVA fiber follow this fascial canal, and then they go vertically until the styloid, the foramen stylomastoidean. On the medial wall, there are 2 anatomical marks. The first one is the marks of the middle circular canal. Just below it is the mark of facial canal, which house the facial nerve. This tunnel starts from the geniculate ganglion and extend horizontally to the posterior wall to begin its descent downward to the stylomastoid foramen. In this cranial view, the facial nerve leaves the posterior cranial fossa to join the geniculate ganglion at the angle of the anterior wall. From the ganglion, the parasympathetic fiber emerge. From the ganglion, parasympathetic fiber emerge as greater petrosal nerve going to foramen lacerum. This parasympathetic fiber mix with the sympathetic fiber of the deep petrosal nerve to form the Vidian nerve. From the superior salivatory nucleus, great petrosal nerve comes to geniculate ganglion, and from there it goes to the foramen lacerum to mix with fiber coming from the sympathetic fiber and to form the Vidian nerve or nerve of pterygopalatine canal. Both sympathetic and parasympathetic fiber, they go to the pterygopalatine ganglion. Let's move to talk about the promontory, which house the tympanic plexus. Promontory is a bulge that, when it protrudes, appears as a bump. This is called the promontory. In the medial wall, there is a prominent bulge called promontory, which is a network of nerve, tympanic plexus. It is the imprint of basal turn of cochlea. Oval window connect to stapes by annular ligament. Stapes move not like a piston, but like a door abutment of the window. A round window connected to secondary tympanic membrane. How lesser petrosal nerve is connected to promontory. From the inferior salivatory nucleus of glossopharyngeal nerve, passing through the jugular foramen and going downward, some preganglionic parasympathetic fiber detached from the nerve. And some touch, pain, and temperature separate also from the level of inferior ganglion of glossopharyngeal nerve 9 nerve. Fiber go superiorly to a bony inferior tympanic canaliculus, emerge to the floor of the middle ear through tympanic nerve, a branch of a glossopharyngeal nerve, and it reached the promontory. They form the network of tympanic plexus that supply the middle here. From promontory, from tympanic plexus, bundle of nerve go across the anterior wall, and they pierce the thickness of the anterior wall to emerge into the medial cranial fossa. Then fiber, they go to the foramen oval to emerge in inferior temporal fossa to reach the otic ganglion. Postganglionic fiber go through auriculotemporal nerve to supply the secretomotor fiber of parotid gland. In addition, from the sympathetic carotid plexus, there is some sympathetic fiber that go in to the promontory to join the tympanic plexus. Correlation, clinic correlation, cholesteatoma. Cholesteatoma, it's a misnomer. It's not a cholesterol, it's not a tumor. It's a sac of a stratified squamous epithelium, mass that keep growing. It just after chronic otitis media. It is dangerous. It could kill. It secretes certain products that can destroy the bony component of the middle ear. Some products are collagenous, digest that the bone and any structure around. It secretes substance that stimulate osteoclast in the bone, it in itself. It can perforate tympanic membrane. In its part flaccida, with very offensive smell and squinty discharge. It can damage oval window, incus, malleus, and stapes, giving conductive deafness. Facial palsy, because the lateral semicircular canal is affected, it can give vertigo and tinnitus. Otosclerosis or ankylosis. In the middle ear, there is inappropriate body formation around annular ligament and around oval window, especially the footplate of stapes. Progressively, this impairs the movement of stapes, leading to conductive deafness by impairing the free movement of plates of stapes. Processus cochleaiformis. It is a chirurgical landmark to do not harm facial nerve and geniculate ganglion. The facial nerve with the nerve of stapedus. Stapedus muscle inside the pyramid is attached to the neck of stapes. When there is a loud sound, stapedus muscle contract, causing the tilt the footplate of stapes to restrict the movement, preventing the inner ear from excessive stimulation. It's a protective reflex for higher cell. The muscle contract also when a person talks, to avoid to hear much for himself. Tendon of tensor tympani muscle is connected to a hook in the medial wall as process cochleariform, which itself is attached to the handle of the malleus. If the muscle contracts, it will pull the handle medially, making the membranous stance, hence the name of tensor tympani. Thank you for watching this episode of Médecine in 3 minutes. Would you like to click the button like and subscribe? Your suggestions are very welcome. Thank you.